You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hi, everyone. Welcome back to the podcast. My name is Sandra Smiley, and I use she, her pronouns. I am an uninvited guest on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm also a final year medical student at the University of British Columbia. We learn in our medical training that factors big and small have an influence on health. It's not just individual choices or genetic predisposition or people's biology that determine health outcomes. Broader social, economic, political, and environmental forces play an important role in determining who experiences good health and who does not. In this episode, I'm going to try to break down the structural determinants of health for you. What are they? How do we recognize their influence in our patients? And as medical learners and trainees, what can we do about them? To do that, I'm going to pass the mic over to Dr. Yipeng Ge, a primary care doctor and public health practitioner based in Ottawa. He was kind enough to chat with me about these and other questions back in January 2025. Dr. Ge has a ton of great insights to share, drawing on his current practice, as well as his years of studying and working on the structural and colonial determinants of health in so-called Canada, as well as occupied Palestine. Here's our conversation. Okay, welcome to the podcast, Dr. Ge.
Thank you for having me.
Could you please tell us a little bit about yourself?
Yeah, for sure. So I am Chinese Canadian. I am calling in from the traditional unceded, unsurrendered territory of the Algonquin Anishinaabe. I've lived here for the past coming up on 9 years. I moved here for medical school, and I grew up in southwestern Ontario in a place called Waterloo, and then I did undergrad studies in Hamilton, very close to Six Nations of the Grand River, where I learned a lot about Indigenous health and the genocide of Indigenous peoples on Turtle Island. And so as like a first generation immigrant, born in China, lived briefly in Japan, and then came to Canada when I was 4 years old, I had to grapple with identity and with what it means to live and play and work on occupied Turtle Island or the settler colonial state of Canada. And currently, I'm a family doctor, also a public health practitioner, and I practice family medicine as well as refugee health. And I do some work around the social determinants of health, including the colonial determinants of health, as one of the biggest and major contributors to poor health from Turtle Island to Palestine.
So you've been a lot of places and done a lot of things. What is it in your life's journey that brought you to a career in medicine?
Yeah, I mean, it was probably from bearing witness to genocide of Indigenous peoples on occupied Turtle Island that really threw me for a loop around what it means to be a settler, what it means to be an immigrant, what it means to practice allyship or accomplishship in moving the world and society, or even just the spaces around us in a better direction than ones that are extremely harmful to health. And so when I learned about, like, truly learned about the history of Indigenous peoples in Canada in my first year, second year of undergrad studies in Hamilton, really close to Six Nations of the Grand River, which is also close to where I grew up in Waterloo, and knowing that the conditions of health and the determinants of health are just so different and made different because of colonial policies and practices, that ultimately led me to think about health in the broadest sense, and then zooming into how do we change these conditions, change these structural conditions. And it made me think about entering public health, and I actually worked at the World Health Organization before entering medical school. And then I decided to enter medicine in conversation with a lot of different folks who mentored me and taught me about Indigenous health, like First Nations, Haudenosaunee scholars and clinicians, and community members and activists in the general region that is like southwestern Ontario. And it really propelled me into thinking about how do we try to dismantle these things, these forms of oppression, from within, and there's, significant limitations, as I've experienced with like the Palestine exception, for example. But that ultimately really was the catalyst to lead me to go into medicine and public health.
Yeah, so what I'm hearing is that it's really been seeing these structural determinants of health and their outcomes in real life that have pushed you toward the study of medicine and ultimately the practice of medicine. Can you tell us what that means to you, what the structural determinants of health are for you?
Yeah, I think to put it like in plain language, is the things around us that affect our ability to be well in this world or to also experience disease and illness. So it includes everything from if we have good social connections, like knowing who our neighbors are, who are in our community, who can help us when we have issues. But there are also the material things that we see. If we're able to put nutritious food in front of us, if we have a roof over our head, if we have education or income to be able to provide for ourselves and our loved ones. And then more broadly, just the ways in which we kind of navigate and experience the world. Like if we're able to walk safely on the streets, if there is a street, and how we access services, including going to the grocery store to pick up food. All of the ways in which we navigate our lives are informed and created by these structural determinants. And then we also have to think about how those things are designed in the first place. Are they designed with us in mind, or are they designed with other people's in mind, certain people's? Then we also think about, or at least I think about, the legacy of colonial or racist policies and practices that inform how people see each other in this world, but also very much inform how society is still structured. So being Chinese, for example, or of Chinese background, there's the legacy of the Chinese Exclusion Act and the impacts of how settler colonial Canada decided to bring Chinese immigrants to build the Canadian Railroad. And then when they didn't want Chinese immigrants any longer, they said, "Oh, we'll actually introduce a head tax and tax people." And that when that didn't work to kind of dissuade Chinese immigrants, they just excluded people entirely with a new bill, with a new bill that turned into law, into an act. And then if we look at other populations, like, for example, First Nations and Inuit Métis, there are systematic policies and practices that make it so that there's actually like an apartheid condition in which people can access healthcare, let alone many other services, and is very much still informed to this day by the Indian Act, which is also a horrible colonial name to relate to Indigenous peoples here. So these broader policies all have a role in which we see the material conditions all around us and also inform how, for example, because I work in healthcare, informs how people interact with the healthcare system, how someone who is in a group that is oppressed or colonized, how you interact with the healthcare system, how you interact with doctors and nurses, and how trusting you are of them to put your life, your health in their hands. And there are many situations like Brian Sinclair in Winnipeg or Joyce Echequan in Quebec. These are people who have died because of medical neglect, but actually just social murder at the hands of healthcare providers because their lives are not seen as equal, their voices are not seen as legitimate. And these are some of the most egregious examples of structural racism manifesting as very individualized cases of that experience of structural racism and colonialism within the healthcare system.
I'm curious. You gave a couple of examples of cases where the structural determinants of health have hugely acted to the detriment of individuals like Joyce Echequan, whose story is a terrible mark on the record of the health system in this country. How do the structural determinants of health show up for you in your clinical work? Can you give us some examples of how you see these determinants of health playing out for your patients?
I mean, it was one of the things that I noticed very early on in medical training was we have this opportunity as patient-facing healthcare workers, as a doctor, to interact with patients on a one-to-one basis. And then you think about the ways in which they present for any kind of condition. And sometimes you think, and oftentimes we think, okay, how do we treat those root causes? Like if someone presents with diabetes or high blood pressure, why was it that they presented in this way? And some of the things that often affect these things are behavioral or lifestyle. And then if we think more broadly, then they become structural. If people are able to access healthy, nutritious food, if they're able to like have a job, to be able to have extended health benefits, for example. All of these things affect the ability of someone to be able to treat disease and illness, but even to prevent it in the first place as well. And so then you have like a disproportionate number of certain patients or groups of patients from certain populations that you worry more about when they come to the clinic. And one of the challenges as a healthcare provider, as a doctor that works in healthcare, is we know that the ways in which healthcare is practiced in large part in the West is this biomedical medicine that really focuses on disease and illness rather than prevention, rather than holistic well-being. And because that is the case, we focus so much on the diagnosis of disease and illness and then treating it with the tools that we have, which is usually medicines or certain therapies. And usually that is not addressed the root causes. And so knowing that some of my patients, their priorities is not even their diabetes or the high blood pressure. It's actually being able to feed their children by having a job that pays enough to feed their children, or finding a job. You know, one of the examples I keep thinking about as I'm talking right now was or is a patient of mine who has a cancer, and they actually need a certain kind of chemotherapy treatment. Because it's not first line, it's like second or third line, they require extended health benefits, like an insurance plan to cover it. And they just lost their job. And so we're actually looking into other kind of compassionate programs through the pharmaceutical company to be able to cover this medication for them. And so who is allowed to be able to access what we think is universal healthcare in Canada is a really important thing to consider when we talk about the ability to be well, or the ability to be able to be diagnosed with a condition, and then to even like go through the stages of treatment and management. So it affects all of the ways in which people experience the healthcare system, because there are patients that don't even come to the clinic, right? I've worked with people who are houseless or homeless in the shelter system in Ottawa, and they don't want to go to the emergency department. They don't want to interact with the healthcare system whatsoever because they've had horrible experiences of neglect and stigma within these systems. And so they access other kinds of care that other people have identified. This is like you bring the healthcare to them. But I always wonder about who is missing, like who doesn't even show up to the clinic, because the people that show up to the clinic are usually able-bodied, or are showing up because the clinic is accessible in some ways, but might not be in others. And so there's so many limitations in the ways in which healthcare is currently structured to systematically dehumanize and also disincentivize people from accessing care in the first place. So it's all of those levels. It really opens up, I think, a whole can of worms in terms of like how do we think about equity in accessing and also having good outcomes from healthcare when we know that the way in which healthcare is currently structured is a illness and disease centered approach to health.
Dr. G, that's really interesting. And as you were talking, I was thinking about practical things that folks listening to this podcast could carry forward. I'm wondering if you've identified any workarounds to some of these structural barriers to accessing healthcare that you were just describing. Do you lean on your allied health colleagues? Do you have an outreach worker in your clinic? Yeah. Have you identified any sort of clever workarounds to the fact that the way that our healthcare system is by and large set up is very difficult for a lot of people to navigate?
I mean, it all has to depend on like the local context, and like the work that you do as a healthcare provider should ultimately and is ultimately like for the people, right? For the community. And so it needs to be able to respond and adapt to that. And part of that is knowing who is in your community and what their needs are, and being receptive to change so that you're adapting to those things. And also, I really appreciate you mentioning like other care providers within the healthcare system, because like everyone has their really important areas of expertise and needs to be able to kind of practice that maximum scope of what they're able to do and contribute, and utilize all the different skills that different people have, and to provide that kind of team-based model of care and really meet communities where they're at. And to be able to do that, sometimes we really have to rethink like what healthcare can look like, right? It doesn't have to happen within the four walls of a clinic or a hospital or an emergency room. I think about models where I have worked in where we're delivering care like in the shelter system in Ottawa, for example. But it is still really challenging because when you're doing care like that, it's such a clear example of the social determinants of health because people don't have housing. And what will improve everyone's health here is they are no longer in the shelter system and they are in stable housing. And so you wonder about your own complicity and complacency by operating within these systems of doing the work that essentially allows for these systems of oppression, like, for example, capitalism, to kind of continue to do what it does and actually just drives more and more people into homelessness. But you can't do everything. You can't do everything as a person, but you try to do what you can with the skills and the resources you have, but also working as a team with other people, hopefully like-minded people around understanding the importance of social determinants of health so that you can slowly address them and draw attention to them and hopefully work to dismantle them. And there are different kinds of models where there are primary care providers that are like prescribing people time in nature or prescribing people social housing. Like these are different ways in which, as healthcare providers, we use the privilege that we hold through institutionalized medicine to rethink what we can do with a prescription pad. And that is just like one example of many that we can rethink how we approach like health in the broadest sense.
Excellent. You just wrote the social media post that I'm going to use to promote this episode. The rethinking what you can do with a prescription pad. That's really good, and definitely something I'm going to be thinking about for some time. I want to switch gears a little bit and talk about your experiences in Gaza. So you've been very active in advocacy about the ongoing attacks on Gaza by Israel. You traveled there not too long ago, right, to provide direct patient care. Can you talk a little bit about why you went and what you did and what you saw during that experience?
Because I've studied the impacts of settler colonialism on health on Turtle Island, I ended up studying that exact same concept and issue as the root cause of disease and suffering in Palestine affecting Palestinians. And when October 7th, 2023 rolled around, I was extremely worried as to what would be the Israeli response. What ended up happening was I shared a few social media posts, including just photos from my own travels to Palestine. And the University of Ottawa suspended me from my residency training in public health. I was already trained as a family doctor at that point, and so I thought about how to continue to center the people of Palestine as I'm bearing witness to genocide. We know that settler colonialism and genocide are one and the same by definition, by practice, by what happens to the indigenous body and the indigenous land. It is true in Turtle Island, it is true in Palestine. And because that was the case, I connected with folks that have been doing this work for quite some time in working in Gaza as healthcare providers, and the opportunity came up, and then I ended up deciding to go to do what I can with the skills that I have as a family doctor to provide primary care, primarily in Rafah in Gaza. This was February of last year. So we're actually coming up on it almost a year. And at that point, what I was seeing was a lot of starvation and malnutrition. And now we know many deaths have occurred this way because of forced starvation, because of the aid and the food and the water that isn't allowed to enter Gaza in any kind of unrestricted way that meets the population's needs, which is another form and arm of the genocidal campaign on the Palestinian people. And in fact, the clinic that I worked at in Rafah no longer exists, and the majority of the population has been pushed out of Rafah and into the Mawasi area, into the central Deir el Balah area, and also in Western Khan Yunis. So people are getting pushed into smaller and smaller places when we already know that people have said that the Gaza Strip is an open air prison. It's one of the most densely populated places in the world. And so it's just absolutely horrific what is still happening to this day.
Mm. Thanks for sharing those experiences. And as I understand it, Dr. G, when you returned, you were asked to provide testimony for some international legal proceedings that were in the works relating to the alleged commission of war crimes in the region. I wondered if you could talk a bit about that and the unique ability of physicians to bear witness to and challenge injustice as you see it.
I think I had a sense that that would be my role, but it wasn't super clear to me until after I returned that the most important thing that I could do from that moment on after returning from Gaza would be to speak about the genocide in Gaza, especially sharing the things that I witnessed on the ground as I was working in the primary care clinics, but also just amplifying the stories, the countless innumerable stories from healthcare workers and civilians on the ground in Palestine, in large part because the Western world has demonized Palestinians in their narratives to delegitimize any of their stories and to manufacture consent for the ongoing genocide, but also the Israeli campaign to not allow in any really meaningful way anyone else. Only healthcare workers have been really entering with some kind of consistency, but even with that, it's not even close to meeting the demands of the healthcare system in Gaza that has essentially been forced to collapse since October of 2023, like over 15 months ago. And so, one of the most important things that I think for us, and there are like hundreds of us now that have entered and exited Gaza, is to speak about the genocide, because doctors cannot stop or end the genocide, as Médecins Sans Frontières said before, when they were bearing witness to the Rwandan genocide and pulled out of that operation because you know, you wonder about the complicity, once again, and complacency of healthcare workers in the humanitarian space that actually allows Israel to continue what it's doing by being on the ground and saying, oh, we're actually providing healthcare through a humanitarian lens. And it actually allows that existing system to continue to genocide more and more people. And so, yes, I provided like multiple different forms of testimony and written testimony, oral testimony to different groups and organizations. And some of that fed into the ICC case, the ICJ case, with the hopes that bearing witness and to tell these stories, that it would change something, it would do something. And I still think we are still in that phase of trying to push to change things. Like I joined many other healthcare workers who returned from Gaza who were based in Canada on block as a coalition. We wrote to the Canadian federal government and we didn't receive a reply whatsoever. And that letter was sent in August of last year. And so we know that these complicit states, but also many other kinds of like forms of complicity in Canada, like weapons manufacturing companies who continue to send parts to the US to build the F-35 fighter jets. They're dropping the 2,000-pound bombs in Gaza. Like they continue to do what they're doing. But we have to, yeah, absolutely continue to push and to share these narratives and stories. But these systems take so much time. to get the kind of accountability and justice that people hope for. And it's not going to be, I think, the justice and accountability that anyone who has been oppressed, it's not going to be meaningful, right? Because I think about the Truth and Reconciliation Commission. And have we had meaningful, truly meaningful action to decolonize, to move towards reparations through authentic reconciliation? Questionable, right? Because we're asking systems that were built upon genocide and colonialism, fueled by capitalism, to suddenly change their ways and to right these wrongs and do more than statements and gestures, symbolic gestures. And so I think we really have to rethink how these movements can really provide alternative systems and institutions that really are life affirming, that are not founded upon genocide and colonialism. So I do look towards indigenous-based ways of knowing and literature. I think about the Land Back work at Yellowhead Institute and how we need to really sharpen those demands and also continue to learn about the different tactics that are used across the world for meaningful decolonization. Because ultimately that is much closer to, I think, accountability and justice, honoring what people who experience colonialism and structural oppression have been demanding for generations, decades.
Dr. G, you've preempted my next question, which was pointing out or marrying two things that we've talked about here. How do you navigate that tension between what the healthcare system, the role the healthcare system has often played in structural violence, and this responsibility that physicians have to combat it?
I think it's a great reflection because it is such an important tension that exists, that to kind of participate in the existing system, as many of us are, arguably probably all of us to some degree, there is that tension of like, how do we still acknowledge that and try to change that if we want to change that? Because not everyone does. And I think to be able to find others that acknowledge it for what it is and also are uncomfortable with that tension, then it brings us closer to the collective action that is absolutely necessary to change the system and arguably to dismantle and abolish it. But this is really challenging and difficult work because these systems were not made in a day. They were made over many, many years, many generations. But where there is structural oppression, there are always forms of resistance. We have to have our eyes wide open to what's happening, and we have to work with other like-minded people. And if there aren't other like-minded people, sometimes it's, a lack of political awareness and knowledge and education. And so being able to do those things so that we kind of try to build coalitions of the willing, trying to create collectives that can do the work of political education, because we know that these existing systems of education, whether it be in medicine or more broadly, are usually extensions of the quote unquote empire that tries to allow for the existing status quo to continue unchallenged. We have examples even here in where I'm calling in from, in Ottawa, where we have protesters who have been calling for an end to the genocide, who have been brutalized by the police, arrested, and have been given conditions where they can't attend further protests or even, speak about the crisis in the Middle East, as the Ottawa police puts it. And so we have to understand the ways in which these forms of oppression are also intertwined and interlinked in the forms of oppression that we so see clearly happen right before our eyes, like the police brutality and oppression that happens to protesters, but to like primarily Black and Indigenous communities who lose their lives, who get murdered at the hands of state and police violence. I think it's all to say that, to not hopefully sound like a conspiracy theorist, is that like it's all connected, that our liberation from any form of oppression is interconnected with other people's struggle for liberation and self-determination from similar if not different forms of oppression. And so what we can do locally sets examples for the people around us, sets examples for other movements for, liberation, so that we can continue to grow and grow and build people power to ultimately dismantle and abolish these systems. But it takes a lot of work, and it's like lifelong work.
Hmm.
It is lifelong work because these things unfortunately predated the many generations that came before us and arguably will continue after us if we don't do anything. So we have to do things to be able to resist these forms of oppressions as it tries to do what it does to put, profit over people, to put resource stealing over anything else. And so, yeah, like I think we have a lot of work before us, but know that is collective work. But because it's collective work, we all have a role to play.
That's a great segue into the question I was hoping to leave off with you on, which is, do you have any advice for medical learners or people early in their medical careers who are similarly passionate about the structural determinants of health and who want to get more involved in advocacy like you've been?
I mean, some of the things that I did in medical school was trying to learn as much as I could about medicine itself as a profession. I remember doing like all these different observerships, like we called them, where you kind of like learn about different kinds of medicine and surgery to know how the system looks from the side of being a healthcare provider. I had a very intimate experience of what it's like to be on the other side, where my grandmother got really sick from end-stage cancer, and to be on that receiving end as a family member, you also see the healthcare system in a really important way to be able to understand how to hopefully change it for the better and know that skills and capacity to do advocacy work in a good way comes with time and practice. I did engage a lot with, like, I was the director of government affairs for the Canadian Federation of Medical Students for 2 years between like 2017 and 2019. And doing that kind of work was one kind of organizing work. It doesn't have to happen within a major institution that gives you kind of consent to like take on this role, to do this X kind of responsibility, where there's like applications, there's like interviews or whatever. Like you don't have to ask for consent to participate in movements for social justice. You have to just have a heart and have really important conversations with the people around you to be like, hey, this really matters to me. And how do we work together to do something about it? And it starts, and I think from my experience, it starts as this like little spark. I think back to the things that I learned in my undergrad, where I was just completely shocked at learning about Indigenous health meaningfully and the history of Indigenous peoples meaningfully for the first time. And then that spark just continued to create a bigger and bigger flame for wanting to change things. And to do that, I think it's a good recipe for burnout if we are not cautious as to how we do that work strategically. And so we have to have people around us, comrades, mentors that we bounce ideas off of so that we don't burn ourselves out. Because one of the huge risks, I think, in medicine is even if you don't think about anyone other than yourself, you can still burn out because of the ways in which medicine as an institution and as an educational system can totally destroy one's identity. So hold on to the things that you care about and in fact be open to bringing more issues in. And I think in my experience was like to be able to think about things outside of medicine, but still have the framing of health as a human right, um, made it so I survived medicine, medical school, residency training, having my identity in all of its ways and the things that I care about still stay true to who I am and to actually grow those parts of myself without giving everything to medicine as an institution. And I think that's probably the thing that I would like leave people with is like being a doctor or being in the profession of medicine is only one part of your identity. Don't let it be your entire identity, because if that happens, then you can fall into an identity crisis when those systems challenge you, because they will challenge you when you try to change the status quo by trying to dismantle these forms of oppression. So have other grounding parts of your identity be well known to yourself and to other people, so that when the backlash comes, because it surely will come when you stand for justice for any groups of oppressed people in this world, you will be well rooted in your identity and the people that care and know who you are and know why you fight and how we fight in a good way, always in a good way towards collective liberation.
Wow. I just wanted to give that a minute. That was an excellent way to end this podcast. What great and valuable insight to share with our listeners. Thank you so much. And having said that, I'm going to ask you, is there anything else that you'd add?
I mean, it's really great that people are listening. I think like I hope if this was helpful too, like maybe pass it on to someone else that you might think would benefit from it, because this is how I've gotten a lot of my quote unquote education, popular education, is people that I trust and respect pass me articles, pass me podcast episodes or certain videos, and in the kindest of ways, they say, like, I think you would benefit from hearing this or watching this or learning from this. And I hope we all kind of grow into this movement culture of like, how do we continue to kind of inspire hope through the things that we do in our solidarity work, but by also continuously educating ourselves and giving each other like these nuggets of things that will keep us going. Because, oh my gosh, it's long and exhausting, but we only get through it if we do it together.
Thank you so much, Dr. G, for being on the podcast today.
Thank you for having me.
That was my chat with Dr. Yipeng Ge, a family doctor and public health practitioner, on the structural determinants of health and our role as medical learners in influencing them. Here are a few pearls that I've taken away from this conversation. 1. The structural determinants of health inform how people navigate their lives, including their ability to access healthcare and the things that they need to be well. The structural determinants of health include material things like housing, income, and access to safe environments and nutritious food. But they also include immaterial things like education, legal frameworks, and policies, as well as institutional practices. 2. The health system itself is a structural determinant of health. Unfortunately, its current design has the tendency to exclude people, including people with disabilities, people living in poverty, people in rural and remote areas, etc. Advocating for patients, leaning on allied health colleagues, employing techniques like social prescribing, and taking doctoring outside of the hospital or clinic are all potential ways of trying to close the gap between the health system and the people who need care. 3. These structural determinants of health are much bigger than you. You alone can't fix the ones that are broken, but you can try to address them using the skills and the resources that you have. Central to this is finding like-minded colleagues who are also uncomfortable with the status quo and who are motivated to change things for the better. Working in such close proximity with people who are hurt by exclusionary and oppressive systems, medical professionals are well positioned to speak out about them and to try and dismantle and reimagine them. 4. The skills to do advocacy work come with time and practice. To become an effective advocate, know the local context, the community that you're serving, and what the needs are. Try to learn as much as you can about medicine as a profession by immersing yourself in clinical experiences. You can join a student group like the CFMS or the Political Advocacy Committee here at UBC to learn the nuts and bolts of organizing. But remember, you don't have to ask for consent to participate in movements for social justice. And as Dr. G says, all you need is a heart and some like-minded people to move with you. 5. Continue to engage with your interests and identity outside of medicine. Medicine is an intense field, and it has the tendency to become one's entire identity. If that happens, you risk experiencing an identity crisis when its institutions challenge you. which they will, particularly if you are at all interested in confronting injustice and changing the status quo. For your wellness, it's a good idea to stay connected to the principles, the things, and the people that you hold dear, and to nurture and cultivate the person that you are outside of the profession. Thank you so much to our guest, Dr. Yipeng Ge. If you'd like to hear more from Dr. Ge or access resources related to our discussion, have a look at the episode description and at our Instagram posts on this episode. And thank you for listening to Just Medicine. I'm Sandra Smiley.
Thanks for tuning in to Just Medicine.